these where I do this, but I kind of want to take it to the next level because we had one recently here. So
T-bar.
Oh, you know what? We'll talk about that too with it.
Okay.
I love it. I love it. So you've got your aorta, right? So what is this to me is one of the like Mac Daddy like trauma things that maybe people kind of think of when they think of trauma that are not people that are outside of healthcare because they don't really know what it is, and that's why we'll explain it. But people that are in healthcare kind of like this is like that crazy trauma procedure for somebody who's comes in as like a traumatic arrest. So what am I talking about?
Dissection.
Not that, because we'll get there because I like your thought.
You're saying for an arrest.
Yeah, what can we do for a traumatic arrest to try to save their life from a trauma surgeon standpoint?
Can you do the balloon in the...
Okay, because we'll talk about that too, because that's a more minimally invasive way of, because you've had this lecture where, what's the maximally invasive thing?
Clamshell?
Yeah, so fastest way to a woman's heart.
Yeah.
Left anterior lateral thoracotomy. Okay, so I want to talk about ED, or they call it resuscitative thoracotomy. Okay. So what am I doing in that? So it's a patient who comes in who's a traumatic arrest. We still go through ATLS and still do a primary survey, but they have no pulse, right? They're dead. And there's timing to this. Does anybody know about this or know what I'm talking about with timing and the two different types of traumatic injuries? So what are the two different types of traumatic injuries that we think about?
Blunt penetrating?
Exactly. So there's blunt trauma and there's penetrating trauma. Okay? So if I have a penetrating injury, so if I have a knife sticking out of the guy's chest like this, and they come in and they lose pulses, what can I do? I could do a resuscitative thoracotomy. So that's an anterior lateral thoracotomy. So we make a big incision in the chest here. We open the rib spaces with a rib spreader, and we expose the heart. And we can do intrathoracic cardiac massage. We were doing this the other day. So we had a traumatic arrest that came in. It was blunt, okay? And we opened the chest. Because then in the room, they're like, why is no one doing CPR? It's like, no, we're doing CPR. as aggressive a CPR as you can do. We have the heart in our hands, and we are doing intrathoracic cardiac massage, we call it. So for penetrating, the timing on this would be losing pulses within 15 minutes is what most books say. For blunt, the timing used to say like 10 minutes, but it's actually even like some books now are saying even 5 minutes, because the chances of getting someone back with blunt trauma is less than 1%. Okay? Now, we got this particular patient back, and they had such severe injuries once we got them to the OR, they didn't survive. But even just getting them back with that 1%, I was very optimistic and hopeful that we could get something going, which, so now my question is, all right, we do a anterior lateral thoracotomy. We're in the chest. We're doing, so what I always tell anesthesia or whoever's at the head of the bed, I always tell them to do something. What do I tell them to do? Because this patient's intubated. That's A, right? First thing, airway. So they're either intubated in the field or we intubated them in the trauma bay. What do I have them do that helps me? I'm in the left chest. And the second I get in there and I spread the ribs, something's like in my face. The lung. What do I tell anesthesia or whoever's at the head of the bed to try to do to help me? You could hold it, but we need to oxygenate him too. Yeah, so what I say, and it's not talked about anywhere, but I say, hey, can you just push the ET tube in? And 9 out of 10 times it's going to go on the right main stem. And now at least the lung kind of deflates and gets out of my way a little bit. It helps. It helped the other day. Then what do I do here? You should know this answer.
Is that the tamponade?
No, here.
Oh, clamp.
So I cross clamp the aorta. Okay, so we do that. So now any catastrophic bleeding down here is stopped for the moment. and we can try to catch up. So I actually put in a right cordis, a right subclavian cordis, for then which we were giving MTP, okay? And then once we started giving the blood products, the patient went from PEA asystole when they came in into VFib, actually, which was kind of interesting. And then we delivered electricity, and we defibrillated them and got pulses back, okay? Blunt trauma, again, 1%. So, this works. That's why it's called a resuscitative thoracotomy. Now, why do you give more time with penetrating? So again, now I have the patient with a knife sticking out of their chest right here.
It's because that's kind of holding pressure there, and it's not really bleeding.
Well, in theory, now I'm in the chest here. I have the heart exposed. I can theoretically try to even fix something that's going on from from that penetrating injury. So I could theoretically maybe put a suture on the ventricle or something to stabilize this patient, at least to get them upstairs to the operating room. I can open the pericardium to relieve the cardiac tamponade. So there's something that I can do for the penetrating, whereas the blunt, there usually is not. And so let's talk about what you said. So there's the great vessels over here, okay? What is this thing that's an embryologic remnant over here? So it's from the PDA, which is the patent ductus arteriosus, which is a shunt from the pulmonary artery, because blood, while the baby is inside of the mother, doesn't go to the lungs. It gets shunted. And the second we take our breath, the PDA closes, but it leaves something there, which is what?
The ligamentum arteriosum.
Yeah, it leaves around what's called the ligamentum arteriosum. So when you're in a high-speed collision or high-speed, high-velocity accident, you get this shearing force, whether that's DAI for the brain or the aorta, right? So you can dissect your aorta, or you can even get a little tear here, dissection, or a little pseudoaneurysm, and then how do you fix that?
TVAR.
Yeah, so what's called then a TVAR. So what does that stand for?
Thoracic endovascular aortic repair.
Yeah, thoracic endovascular aortic repair. So where we actually put a stent graft here. Now, what can happen with the stent graft?
Coverage of the left subclavian.
You can cover the left subclavian. So now you're putting the left upper extremity at risk. So you need to do Q1 hour neurovascular checks on the left upper extremity. Then what would you do if you had to cover that? There's a procedure we can do to fix that problem.
Some kind of anastomosis? Or?
Yeah, so a carotid to subclavian bypass, okay? That's for the TVAR. Now, you brought up as well, a minimally invasive way to go about this is then this. So what does that stand for?
Oh, yeah, REBOA.
REBOA. What does that stand for?
Resuscitative.
Resuscitative.
Endovascular.
Endovascular.
Balloon.
Occlusion of the aorta. So what we do is we go in the femoral artery here, and we can blow up a balloon here. And there's different zones. Zone 1, Zone 2, Zone 3 is the pelvis. So if someone comes in with a really bad pelvis fracture, and you feel their pelvis and it's unstable, what can you do in the interim in the trauma bay to try to help with that? Put a pelvic binder on. And then theoretically, too, you can use the REBOA in Zone 3 here to help get control, because they're bleeding from these vessels that come off of the internal iliacs. And that's what IR would then do if they were to go and embolize something here. Okay? But the binder is going to close that space and close up that volume. Because if I'm going to bleed to death, what are the different places I can bleed to death into or to?
Abdomen.
So I could bleed to death into my abdomen. So either cross-clamping or blowing the REBOA up in Zone 1 is going to help that. Okay? My chest, I can bleed to death into my chest.
Outside of the bone.
I can bleed to death onto the floor. If I transect my radial artery, I will bleed to death onto the floor. Where else?
What? Oh, pelvis.
Pelvis and the retroperitoneum, I think of.
Yes.
Okay.
What about long bone?
So that's another one that theoretically you can lose a lot of blood even just like from a bad femur fracture into your thigh and develop a thigh compartment syndrome. Okay. But the talked about ones are the floor, chest, the abdomen, the retroperitoneum, the pelvis. That's where you're going to bleed to death. And this is how you're going to try to mitigate that to really get ahead and get that resuscitation to then take them upstairs and try to fix the problem. This is all temporary. The REBOA is temporary. And everyone gets all, bent out of shape. I'm like, listen, the patient's like not alive. So this is like Hail Mary, heroic surgery to try to save them. We're not worried about crazy stuff because they're already dead, okay? Does that make sense? Because that's one of these big, Mac Daddy. When you think of trauma, I think of a resuscitative thoracotomy. Yeah. Who's seen one?